Hello, we are here with Bono's Health, where I know some stuff, but I'm looking to know more things. And I am joined by Dr. Giovanni Campanile, a co-author with me of Healthy for Life. There was 25 of us, all these names down here. And so we're finally connecting, our first time really chatting here. Excited to chat. And he has one of my favorite titles of any book in Live Well Deliciously. Live Well Deliciously. That is a good way to live, I think. I'm a food lover. I'm from Brooklyn, New York, most of my life. And so, plenty of Sicilian food there. Excited to hear a little bit about that. But we're also here to talk about my heart disease. Good stuff, exciting stuff. Just a quick tee up. The burden of disease. I've heard you say this stat: 20 million deaths a year in the Western world. Is that correct?
That's correct.
Yeah. And Dr. Giovanni, where are you joining us from right now?
Key West, Florida.
And he's in the hospital. For those who are watching, if you're listening, you don't get the privilege of seeing this beautiful man. But tell us a little bit about your history. It's well documented. You have your own podcast as well. We want to direct folks to the rest is health. The rest is health. Excellent. With his wife, who is a functional psychiatrist.
That's right.
Functional psychiatrist, similar to my wife, not the psychiatrist, psychologist. So we have some similarities overlap in there in the health and wellness space. So yes, and I've listened to at least one of your episodes. I'm looking to listen to more, and so excited to dive in further. Tell us a little bit more about you, though, Dr. Giovanni.
Well, I'm, I trained as a traditional cardiologist in Boston, and I was a very busy interventional cardiologist, and I had the good fortune of meeting some good people in the, in the functional medicine world, and that opened my eyes to what is out there in terms of how we treat people, not just with medicines and procedures, but also with lifestyle and supplements and diet and exercise. And I became very good friends with Dean Ornish, he's the person who discovered that you can actually reverse disease. And he did it, his method is with lifestyle change. And I became the director of the Dean Ornish Reversal Heart Disease Program for the East Coast and Atlantic Health. And it was a little frustrating being an interventional cardiologist because I put in thousands of stents. And when we put in a stent, we really don't cure anything. It's a stopgap measure. What really cures this completely preventable disease is, lifestyle, exercise, diet, and lowering stress, making sure you're connected well with friends and loved ones. All these things are as important as each other in terms of reducing risk for, the number one killer for men, women, postmenopausal women. A lot of women don't understand when they do surveys that their biggest risk of death is not breast cancer, which many women think is, but it's heart disease. So heart disease is a major issue. And again, it's completely preventable. And also, interestingly enough, once you have established disease, this is one of the focuses of my practice, is that you can reverse the disease.
Love it. And Dr. Peter Attia talks about the 4 horsemen of the apocalypse. He's one of the most popular voices. He just did a 60 Minutes piece as we're recording this here.
Yeah.
Definitely got a lot out there. So just curious real quick, as he's kind of the leading authority, him, Huberman, those two guys seem to be in lockstep. Are you, for the most part of what you know those guys without, throwing anyone under the bus or anything like that, are you more or less in lockstep with Dr. Attia, Dr. Huberman as well?
Yes. I just gave a talk about longevity and heart disease at the Vibrant Longevity Summit, and they were also presenting. So we presented together. I got an opportunity to speak to them. Peter Attia is very, very good. He's not a cardiologist,
right,
but he knows a lot about lipidology, and I think he's advanced the public's knowledge of lipidology to the point where people are now aware of things that even cardiologists weren't aware of a short while ago. So he needs to be given a lot of credit for that because he's a good teacher. And Rhonda Patrick and Huberman,
mm-hmm.
they're very good teachers. And I think in this day and age of where, most people get their information on podcasts, just like your podcast, this is a great service to the public. It's very important to have people out there that are, they do the research in the right way. And this is what I like about Peter Attia. He researches things in a good way and explains it in a way that most people can understand. In fact, when I first started listening to him many years ago, when he first started, I think I was probably one of his first listeners. I thought there's no way anyone's going to listen. The general public's not going to listen to this stuff. It's too high level. But I was completely wrong. I think people are very interested in getting information at a good level.
Yeah, I think a lot of people never heard of an ApoB before. I feel like he certainly
now
brought
it's
that
common
term.
knowledge.
Yeah,
it's funny though. A lot of traditional cardiologists still haven't gone on board about this, and that's a whole other story about well trained, very well trained, good traditional cardiologists are not on board with all this stuff because they they're still on this older pattern of looking at the good and bad cholesterol and not looking at more advanced lipid particle numbers, particle sizes, and especially ApoB, Lp(a), all these factors that are probably more important than the old way of looking at it with the good and bad cholesterol, LDL and HDL.
Yeah, and that is as I'm going through the journey, and I'm excited to hear your free medical advice, and appreciate you again willing to do that. I'm excited to hear that. But yeah, that's something that as I'm going through this journey, listening to the cardiologist I have, the more traditional allopathic cardiologist, if we want to use that term. It's not a derogatory term, I hear. But the other, I'll give credit to Dr. Peter Attia again, the medicine 2.0, trying to keep you alive. That system of you have a car crash, you go into the emergency room, emergency department, and they can take care of you. They can save your life. And then medicine 3.0, which sounds like you're a little more in the preventative side, more advanced testing, starting to use AI. We're going to talk about that as well. So do you, again, like that concept between the medicine 2.0 and medicine 3.0 based on your experience?
Yeah, no, it's a great way to divide things. I don't belittle traditional medicine. Traditional medicine is amazing. It's sick medicine, but a lot of functional medicine doctors, when they say sick medicine, they say it in a kind of a derogatory way. But it's not derogatory. I mean, we do some amazing things. If you're going to have a heart attack, the best place to have a heart attack is in America. I'm in Key West. This is remote. We're closer to Havana, to Cuba, to Havana, than we are to Miami. But we have a cath lab here that I put together. And we do, if you have a heart attack in Key West, even though it's so remote, you still get a stent. And that's what you want. You want to get a stent. And so if you go to many other countries, it's not the case. So our acute care medicine in America is, second to none. It's amazing. But the key to chronic disease is that most chronic disease can be prevented. And what we have an epidemic. We talk about an epidemic of heart disease, coronary disease, but what we really have an epidemic of is elevated cholesterol, and why is that? And that's because lipoprotein molecules are little spherical balls that carry stuff through our bloodstream. And they not only carry cholesterol, but they carry other things that are used to put out fires in our body. So the more fires you have going on in your body, the more lipoprotein molecules we need. So we look at risk factors, the traditional ones that everyone knows about: smoking, hypertension, high cholesterol. But then there's maybe even more important than atypical risk factors, like hormone imbalances, postmenopausal state in women, toxins in the environment, microplastics, stress. We have a lot of stress. We have a very advanced society, and we're under a lot of stress. We're in front of computers all the time. Little kids have to get up early to go to school. It's all these things are stress factors, and the common factor that is associated with all these things is elevated lipoproteins. If you look at babies, their LDL cholesterol is 20. in that range. If you look at modern hunter-gatherers, their LDL cholesterol is about 20. So our natural LDL cholesterol is 20, because I always get this question is, are you getting my cholesterol too low? And that's, that is a myth that we're getting cholesterol too low, because we should naturally be that low. And so by doing whatever we need to do and we get the cholesterol super low, it doesn't affect, the places in your bodies that vitally need cholesterol. Like our brain needs cholesterol, our steroid hormones need cholesterol, our membranes of our cells, but all those areas make their own cholesterol. Only about 5% of cholesterol is in the bloodstream. So even if we got the cholesterol down to 0, you still have 95% of your cholesterol in your body. So, that's somewhat of a myth. It's many times in medicine, we use logic, right? We say you need cholesterol in those areas. If your cholesterol is too low, it's bad, but that's not true. And many, many times in medicine, we find out that, you can't use logic because it's such a complex system.
Yeah. Yeah, I've 100% heard that term, and that's one of the thoughts again. And I'd love to get to my my own health as well, and a couple of things there is yes, that's something I've heard of, getting your cholesterol down, and I've said, hey, I'm in my situation, I'm hoping to avoid going on a statin. I'm 41 years old, turning 42 in a few weeks here. My father passed away of a heart attack at the age of 41. So go figure, I'm checking this stuff out. I tried to go get a CT angiogram to preventatively assess my risk factor at the age of 39. Insurance companies, go figure, won't pay for this stuff until you turn 40. They had a hard stop. So that's why one of the reasons I was told they were originally not going to order it and things like that. And then, so I kind of had to fight to even get that CT angiogram when I was under the age of 40, just to assess my risk factor. So 41 was when my father passed away, a heart attack. For what it's worth, we had just moved from communist Russia. We escaped under political and religious asylum, moved to America, pretty big deal, very stressful. My understanding is he was, go ahead.
Where did he move from?
We were in Moscow.
Oh, wow.
Yeah.
Interesting.
Yeah. 1987, before the fall of the wall. Very stressful, apparently. I was 3 years old at the time. But my understanding, he was smoking a lot of cigarettes, drinking a lot of vodka, as Russians do. Go USSR. But yeah, so that most likely, like a lot of the factors you're talking about, high stress, toxins entering the body at a rapid pace, breaking the body down, certainly led to me following a healthy lifestyle. I would say, with that risk factor knowledge, even as a young child. And my cardiologist, for what it's worth, looking at me, he's used to seeing, folks that are a couple 100 pounds overweight. He's saying, hey, you're like fit. You have, I'm not, I competed in CrossFit. I'm a kind of walking model for, I think, a healthy life for the most part. Now I have a 3-year-old. You mentioned young kids and the stress they bring, whatever that's worth. I'm a busy clinician. I see close to 70 patients a week as a physical therapist and personal trainer, hybrid, mixing the fitness and the healthcare space. My company is called Fit Care, Physiotherapy and Wellness. And if you focus on your fitness, you can avoid the healthcare space. So a little bit of the underlying message of what you mentioned there in your original introduction. So all that to say, went to do a lot of blood work. We did share the blood work with you here. I'm happy to share with the listeners as well. And I would love to dive in right to there, and we can talk a little more about my testing. You have it printed out. Is that right?
I do.
Nice. So yeah, I'd love to hear your take on it. And again, for the folks, just to set this all up, there just seems to be a lot of confusion. And again, as educated as I am, as many thousands of hours of books, podcasts, conversations like this that I've been able to have the pleasure to have and the privilege to have, I'm still confused as to whether I should go on a statin. In fact, I probably am currently leaning towards statins are more deadly, and can cause more issues. And I would love, and I feel like it's a last resort for someone like me who's relatively healthy, does a lot of the other stuff well. But if I have a genetic predisposition, that ultimately becomes the hypothesis or question, and the things that we're trying to answer here is, should I, Bo, go on a statin? So please, let's dive into the blood work that you have in front of you, and I'm happy to again share this on the screen or as a side note for anyone interested. Dr. Giovanni.
Well, first of all, thank you for that. And the idea that, and again, on the internet, if you look up statins, you're going to get a lot of negative impression about statins and that they appear to be the worst thing you possibly do. And that's completely not true. Statins are one of the many tools that we use for managing coronary disease. They do have some good benefits and they have some bad side effects. But they also have some good side effects, what we call pleiotropic effects. And some lipidologists feel that the benefits of statins are much more than just lowering cholesterol. Their pleiotropic effects are that they are antiplatelet, they improve endothelial function, they're one of the strongest anti-inflammatory molecules we know of, and they're very safe. We have now like 30-year data on children that were put on statins at age 6, and now are 30 years later, and there's very, very low signals of anything bad going on. They've looked at, my personal feeling about statins is that they may affect the mitochondria, which, if your listeners don't know what that is, that's the little powerhouse inside the cell that produces ATP, energy. So mitochondria, now in the longevity world, is a very big focus. And if they do, there's no real good evidence that they do affect mitochondria in a bad way. But my fear is that they possibly could do that. I think, there's about 5% of the patients that take statins that develop muscle aches. I think those patients are getting mitochondrial effects. But the problem is, once you develop, I think, off camera, you had told me you had a CAT scan done, a CCTA.
Yeah.
So what a CCTA is, it's a CAT scan with contrast, and the resolution of the slices of the CAT scan are good enough to see the artery itself and see if you have plaque, any subclinical plaque. Now, there's a differentiation here of it's somewhat binary, where you either have plaque or don't have plaque. If you have plaque, then for whatever reason, all those risk factors I talked about, genetics, whatever, you're developing plaque. So you want to stop that in its track. You want it, and maybe even reverse it. I have a growing number of patients that we do a combination of treatments, and we can get their plaque. We now have a way of looking at this plaque with artificial intelligence overread. This is called the Clearly test, where the AI can then take that plaque and differentiate it into either calcified plaque, which is usually pretty stable, unless it's blocking the artery significantly, or into soft plaque, and it's color coded. So blue is calcified, yellow is soft, and then if you have red, that means it's inflamed. And that's trying to assess this concept of a vulnerable plaque. And that's very important, because a vulnerable plaque is the kind of plaque that could rupture. And once a plaque ruptures, that gives you a heart attack. And if it happens in the wrong spot in your arteries, the first sign of a heart attack in more than 50% of the time is cardiac sudden death. So we are trying to prevent something that is lethal and possibly catastrophic, right? So if you need to take a medicine to prevent that catastrophic event, I think it's very worthwhile, especially since we know a lot of these drugs are super safe. And but given that, my initial approach to all patients is, number one, assess, how bad is the situation. Number two, and that is trying to take the least risky approach. Of course, the low-hanging fruit is lifestyle change. Go on a good diet. Assess through testing whether you are genetically producing cholesterol or absorbing cholesterol. There's receptors in your colon in some patients that make you absorb more of the cholesterol or the saturated fats. And if that's the case, then diet changes could be more in your favor. You shouldn't be if you're in that case where you have plaque and you have receptors, you shouldn't be on a carnivore diet. You should be on more of a Mediterranean style diet, or that kind of way of eating. Everyone is different. There's no one way of eating that's good for everybody. So you should exercise. Exercise. I think you get a lot.
Can I jump?
Yeah.
Can I jump in and ask you what is the genetic receptor just for folks? Because if they hear that and they're like, oh, I wonder if that's me. Because again, familial hypocholesterolemia is the term, right? And so a lot of people are worried eating eggs causes high cholesterol. I know there's plenty of studies that show there was a study in New England Journal of Medicine. I remember a guy ate 20 eggs a day for 6 months, didn't affect his cholesterol at all.
He was a medical student.
Yeah.
I think the idea is this, is that I think if you're metabolically healthy, you can eat, there's this whole controversy about red meat, eggs. I think the more metabolically healthy you are, the more you're not overweight, you don't have visceral fat, the more you can eat anything and get away with it, right? So the concept that no one should eat red meat or saturated fat, I think is wrong. I think if you're obese, you should maybe stay away from these things. If you're metabolically unhealthy, you should stay away from these things more than someone who's very fit and metabolically healthy. When you exercise, especially high intensity interval training, it affects your lipids in a good way. You want it, and we know that, as your heart ages, it gets stiff and it gets small. And we know that exercise helps that. So, there's a lot of, we try to look at things in isolation, but you can't look at things in isolation. Everything's connected. Our exercise, our diet, our stress levels, everything's connected. So it's, and there's not one good pattern for everybody. That's the thing.
So you use the term metabolically healthy. My understanding, and again, I believe this was I think it was a U.S. study. It was either New England Journal of Medicine. You might know the study as well. I think it came out a few years ago. I want to say before COVID, maybe 2019, and that data means it's a few years old already. But it showed they used 5 biomarkers. I think blood pressure, resting heart rate, that kind of thing, to determine metabolic health. And Americans were I believe only 11% of Americans, based on their study, metabolically healthy based on using these 5 standards of measure. I don't remember the exact things. I don't know if you're familiar with that study, but metabolically healthy, if we're saying 89% of Americans are not metabolically healthy, then we're getting into some deep weeds on some.
I mean, there's statistic after statistic. With the new standards for measuring obesity, I think 70% of Americans now are classified as obese. Only about 20% of Americans exercise enough. So we are a very metabolically unhealthy society. And and again, I love America. When I'm in other countries, I usually can't wait to get back. But we have a lot of problems. Our foods, our American children, 70% of their diet is ultra processed foods, and Americans eat a lot of things. It's really not. What we talk about a lot is meats. We do meat studies, for instance. This is a big problem. When meat studies are done, I think there's never been a good meat study. When you look at meat, you look at really high quality meat or venison or no pesticides, no hormones, and no antibiotics. And you take that meat. Since this study's never been done, we don't know yet. But whenever you look at meat studies, it's always processed meat.
Right. They include pepperoni pizza as meat. They include Big Macs as meat.
It's no big surprise that this processed food is not good for you, right? So I think good quality meat is an integral part of a good diet. I think eggs are incredibly good nutritiously, even though they have high cholesterol. But your body can deal with this high cholesterol if you do all the other things that need to be done in a good lifestyle. So I think you should be eating eggs. I think you should be eating whole fat dairy, because this concept of the fatty 15, I don't know if you've heard about fatty 15. That's the first omega-3 discovered in, 60, 70 years. And it has incredibly good features to you. You could either buy this expensive supplement, the fatty 15, or just eat good quality whole dairy, that has fatty 15 in it. So these, I think the processing to make dairy low fat is worse than the fat. So even though, cardiologists usually have this misguided focus on low fat things, we now know that's, low fat, ultra processed carbs, that's the worst thing that you could possibly do. I think if you eat a good diet, and if our part of our book, we went to Sicily and we studied centenarians and super centenarians, they eat everything. They eat dairy, they eat good meat, they eat, vegetables, they eat fruit, they eat poultry, they eat steak, they eat everything. So, and they live to be 110. So, this is, the quality of your life and the quality of your food, I think, is really what's paramount.
Yeah, and I'm sure, it sounds like you have a lot of overlap with the blue zones. Most folks might have heard of that listening here.
Yeah.
And even in the blue zones, I think, you alluded to, again, a lot of those things, connection, being active. But yeah, even the majority of blue zone cities include, I believe, a glass of wine with dinner every night, or a glass of alcohol.
I mean, alcohol now is becoming a whole different topic in and of itself. But the blue zones is a good example of, what happens here. We get on these bandwagons where grains are bad, or, so don't eat grains. But don't eat bad grains. That's the idea. In Sardinia, Italy, the longest living men in the world live in Sardinia, Italy. Their diet is 70% grains, but they have like incredible grains. They have like really good grains.
Ancient grains.
Ancient grains. So we tend to look for silver bullets in America because that's the way we are. But I think that's, that could be misleading. So to get back to you, you did the CAT scan and it showed some disease. So I think you have to take that very, very seriously. I would do everything you can to get your apolipoprotein B, or more specifically, the apolipoprotein B capital A1 ratio. And again, that's a little confusing because apolipoprotein small a is bad and capital A1 is very good. The higher, the better. And so the ratio of ApoB to A1 is really the most important thing. There's a meta-analysis looking at this particular BA1 ratio, and it directly correlates to MACE, major adverse cardiac events. The higher that number, the more MACE you have. And the lower, the good news is we can almost get that ratio. If we get that ratio down to low level, then you almost get your risk down to zero. It never goes to complete to zero, but it goes very close to zero. And so my feeling is, let's forget about focusing in on what medicine's good, what medicine is bad, what thing is good. I think my approach is, if your coronary disease is mild, like yours sounds like it is, you have the luxury of time of doing the right thing. Make sure, you're a physical therapist, so I'm sure you're exercising well. And my recommendation for exercise is always, a zone 2 aerobic exercise, alternating with some form of high intensity interval training because of the good effects on the heart, and some weight training. We saw your biceps, so I think you're doing the weight training. So
I ran a CrossFit gym in Dubai for a few years. I competed in CrossFit. I was doing the things, and that's a little, what's the frustrating thing is you think you're doing all the right stuff. And one of the things, back to the big picture of cholesterol, just for folks, because I think maybe we want to put that into some context. I don't know if we're completely dismissing just that basic LDL, HDL number. But HDL, it seems to me, the one thing that can get it up, and it seems that a lot of the conversations are around the risk factors, is a low HDL, which I seem to have a genetically low HDL. You can certainly tell me if you think there's validity to that. But around 2008, 2009, that we're talking 15 years ago, 16 years ago, I remember having it tested. It was in the 40s. It was low 40s. That conversation with it was my general practitioner at the time. He said, yeah, whoever figures out how to, give you a pill to increase your HDL to protect your heart, as the good cholesterol, quote unquote. We're putting quotes around this. But he said, yeah, whoever figures that out, they're going to be a billionaire who can figure out how to give you a pill to increase your HDL, because he thinks that's, cardioprotective. And I basically,
I would make a little comment on that. First of all, just knowing HDL doesn't mean much. You have to know, HDL, we think reflects reverse cholesterol transport. That means sucking the cholesterol out of your cells. But we don't have a good test of HDL function. In fact, there are some people with super high HDLs that have a high cardiovascular risk because paradoxically they have dysfunctional HDL. So the HDL, we don't really look at as much as we do the LDL or the ApoB. In fact, we don't use, I don't personally use niacin because their data on niacin is not good. It lowers cholesterol and it raises HDL and it lowers triglycerides. It seems like the perfect drug,
right?
But it's not. There's no study that shows improved outcome with niacin. So whenever we give you something to lower your cholesterol, what's more important than just lowering the cholesterol is the outcome data. Does it lower your cardiovascular risk? Because if it's just cosmetically lowering your cholesterol and your cardiovascular risk stays the same or goes up maybe, because in niacin, some trials have shown an increase in overall mortality, then it's not worth it. So, and niacin may affect other things. That's why it may affect the mitochondria. It may affect other things. So I don't use niacin, but I do use, in your case, I would be, if your HDL is low, that's sometimes an indication of metabolic health, insulin sensitivity. If your insulin sensitivity is off, that can affect your HDL. So, I use things like continuous blood sugar monitors to make sure your blood sugar isn't affected by foods you eat, measuring your insulin level, measuring your C-peptide, measuring your hemoglobin A1C, because those all affect triglycerides and HDL. And that's a very important factor because if your insulin sensitivity is not correct, then that affects the endothelium. The endothelium is a single cell lining on the inside of the arteries. We have 60,000 miles of arteries in our body. Every single artery has an endothelial lining inside, and the function of the endothelium is very important. And the current thinking is that has to break down before cholesterol can get through and get into the cell wall. And then there's an additional lining on top of that called the glycocalyx, which is a fascinating new find. It's a hairy-like structure. You need an electron microscope to see it. But so that barrier has to break down, the endothelium has to break down, and then you can get disease. So, HDL and insulin resistance may be an indication of endothelial dysfunction. And that's why it's critically important. It's fundamental.
Interesting. Yeah. Again, you have my blood work in front of you. The A1C, I believe, is 4.9 or 4.7 on the lower side. I don't think I've ever really had issues with insulin per se, as far as testing wise, metabolically. It's one of the last pages, I think, if you're looking at it. But I would say I notice, I generally carry around a little bit of extra kind of fluff around my belly, despite, again, working out at a pretty high level. And I would never consider myself very lean, no matter how clean my diet was, no matter how much working out I was doing. So maybe there is something to the insulin piece. I just wonder if there's different testing that
first of all, on this testing alone, your HDL cholesterol is low normal at 40, and then you have an LDL pattern A, but you have a peak size that's 218.7 angstrom, and so that's a little discordant. The LDL AB classification means the size, but because the peak size is a little on the low end, you may have some issue because your HDL is a little bit low normal. You have this discordance between the LDL pattern and the peak size. That means that there may be some insulin sensitivity issues going on here. Either a predisposition, sometimes you just have a genetic predisposition to insulin sensitivity, or your diet is such that you may have to reduce your carbohydrate intake, and that's usually the best way to deal with this, is to really lower your carbohydrate as best as possible.
Okay, good to know.
You want to lower your triglycerides are 112, we like to see that below 100. Above 150 is abnormal, but these are, it's above where I like to see it. So I would try to lower triglycerides. Again, triglycerides are part of the lipid panel that's most responsive to carbohydrate intake.
Mm-hmm.
So what I usually recommend, you're not my patient, but in general, what I usually recommend is, reduce refined carbohydrates and sugars.
Mm-hmm.
If you drink a lot of alcohol, alcohol is a lot of sugar. So it's, reduce your alcohol intake, increase your soluble fibers. That's very important, like oats, barley, lentils, apples, these kind of things. And swap any, like if you're eating too much saturated fat, I'm a big believer that you should eat some saturated fat, but not too much.
Mm-hmm.
And if you're eating too much, then I would replace it with monounsaturated fatty acids like extra virgin olive oil, avocado, almonds, walnuts, fatty fish, this kind of thing. So there are dietary ways to deal with this. And one thing I give my patients is a functional salad dressing. Garlic, olive oil, and capers are really good for your arteries. So I tell them to take 3 to 5 cloves of garlic, crush them, wait 15 minutes, because that activates the components of the garlic, the allicin, the allicin, the allyl sulfides. And so you get like 100-fold more of those components by waiting. You put it in the olive oil, and they're fat soluble, so you get this high concentration in the olive oil in a glass jar. And then you put a tablespoon of capers. Capers has the highest concentration of quercetin of any food. And so you mix this up, save it in a cabinet, not in a refrigerator, make it every week, and then use 4 tablespoons of this every day. It's like a functional salad dressing that improves endothelial function and lowers cholesterol.
Fascinating. Yeah.
So this is just an example of, how to deal with things in a more natural way.
Yeah, and again, I think a lot of that stuff I do, but certainly, maybe if I have 1 glass of alcohol a night, I could cut that down. Even I've done periods, dry October or sober October, whatever, that kind of thing. But yeah, I think it's going to be interesting to again identify with some of these. At this point, I guess it sounds like yellow flags on my blood work that we can certainly start cleaning things up. We do want to cut. We're going to cut off here only because we both have something on the top of the hour here, so I want to respect your time and really appreciate this. So I'd love, again, feels like we could talk about this, dive into it for multiple hours. So perhaps
this can go on and on. But anyway, I appreciate being on your podcast. This is great. You're doing a big service for your listeners, and thank you for having me on. So.
All right, thanks, Dr. Giovanni, and we'll have show notes and everything where folks can find you, and would love to follow up.
All right, be well, Bob. Bye-bye.
Have a good one. Bye-bye.